Okay.
So let's get started. Hello?
Hold on, there's like an error, I think.
Hello?
It says unable to connect right here. Oh, it's going.
Hello? Can you hear me now? Okay. Let's get started. Can you hear it now? Can you guys hear me? Is this working? Yes? Okay. All right, guys. Thanks. So we're going to talk about something completely different for the next hour. And actually, this is not the beginning, because I know you had a talk yesterday from Dr. Shamoun on type 1 diabetes. So we're going to jump in and take over for him. But we're going to have actually a series of talks over the next few days. So I just put up the schedule of our diabetes schedule. Diabetes days for the next couple of sections. So today we're going to talk specifically about type 2 diabetes. On Monday we're going to spend a whole hour talking about specific drugs that are used to treat predominantly type 2 diabetes, although we'll also be talking about insulin. And then we'll begin our discussion about diabetes complications, which will continue on Tuesday morning. Dr. Arezzo is actually going to come and talk to you about diabetic neuropathy. And then I think one of my favorite things, and I think it's been pretty well received in the past, is I actually have a patient of mine who has type 1 diabetes, and she's going to come in and talk with you and tell about her experiences living with diabetes. So that'll be on Tuesday morning, followed by our case conferences. Okay, so let's jump in. So I'm going to start by actually referring to this very famous person in the history of diabetes. His name is Harold Rifkin. And I remember actually hearing his quote back when I was a medical student. And he said sort of famously that to know diabetes is to know all of medicine. So the point is that diabetes really has a major impact on organ function, on total body activity, and that if you really understand the pathogenesis of diabetes and the consequences of diabetes, you've pretty much mastered all there is to know about medicine. But it turns out that Harold Rifkin is a very important person, and he was he's a founder of the American Diabetes Association, a very famous professor of medicine, and he was here at Einstein. He was an early professor of medicine here, and also director of the diabetes program at Montefiore Medical Center for many, many years. So he's kind of the link that we have to the past, and really kind of highlights that diabetes has been, both in the research arena and in the clinical arena, a major strength of our institution here at Einstein. So I couldn't neglect to mention Harold Rifkin. Okay. So this is a sort of an outline of what we're going to go over today. We're going to define what diabetes is, talk a little bit about the epidemiology. We're going to spend quite a bit of time talking about the pathophysiology, exactly how is it that type 2 diabetes develops, talking about defects both in insulin availability and insulin action. We'll spend some time talking about genetic and environmental influences on type 2 diabetes. Clinical presentation, what does it look like? How do you know somebody has it? And then a little bit about treatment and prevention, but with the understanding that we're going to go into the pharmacology and drugs on Monday. So what is diabetes? Well, I think this is a little bit of a review, because obviously you've already been thinking about it and heard about it from Dr. Shamoun. But this is sort of how I tend to think of diabetes. which is that it's really not one single thing, but it's really a number of heterogeneous disorders which share two common clinical features. The first one is abnormalities predominantly in carbohydrate metabolism, but also protein and fat, that are due to either relative or absolute deficiency of insulin. And so the result is hyperglycemia. So the characteristic feature of diabetes is hyperglycemia. And it's also end organ damage or complications that result from hyperglycemia. So the complications including damage to eyes, kidney, neuropathy, blood vessels, and the heart. So it's hyperglycemia and vascular complications, but within that paradigm, there's a lot of heterogeneity. And so just to contrast type 1 and type 2 diabetes, again, what they have in common is hyperglycemia and the risk of vascular, especially microvascular complications, retinopathy, neuropathy, and renal disease, and we'll talk more about those next week. These are the things that both forms of diabetes share. But on the other hand, there are some unique features. Whoops, sorry about that. Okay. There are some unique features of type 2 diabetes that type 1 doesn't share. And that's an association with this constellation of features that are often referred to as the metabolic syndrome. So type 2 diabetes is associated very strongly with obesity, and we'll talk more about that, with characteristic lipid disorders, dyslipidemia, hypertension, cardiovascular disease, and I put up polycystic ovary syndrome here, which is a common disorder, reproductive disorder that's also associated with obesity and type 2 diabetes. On the other hand, type 1 diabetes is associated with other autoimmune disorders, right? Type 1 diabetes is, in most cases, due to autoimmune destruction of pancreatic beta cells. And so you see other autoimmune disorders in conjunction with type 1 diabetes. Very commonly, actually, thyroid, either Hashimoto's thyroiditis or Graves' disease are both relatively more common in people who have type 1 diabetes. And I put this little animation here just to remind you that type 1 diabetes is much less common than type 2. Type 2 diabetes accounts for about 95% of diabetes cases in adults, especially in the United States. So most of the diabetes that you're going to see clinically will be type 2 diabetes. Okay. So diabetes in general is heterogeneous. You have type 1, you have type 2, you have other intermediate phenotypes, which we'll talk about briefly. But type 2 diabetes itself is heterogeneous. It changes over time. It's different in one individual from another, although certainly there are common features and classic features that we can, that we can focus our attention on. But I want you to get the idea that it doesn't always look the same in every person who has it, and it doesn't always stay stable over time. So the common form of diabetes, which we're going to spend really most of our lecture today talking about, is considered to be a polygenic disorder with a very strong environmental component. But there have been some rare syndromes, single gene defects or monogenic forms of diabetes that have also been described. And I just put them up here to kind of contrast for you the complicated, polygenic, environmentally influenced type 2 diabetes that we're going to really focus on today with these somewhat rare, very rare disorders of single gene mutations that can cause diabetes. The most well-known ones are called MODY, or maturity onset diabetes of youth. These are syndromes of mild, what looks like type 2 diabetes, but it occurs in children who are not obese. And a number of single gene mutations have been identified. But overall, MODY probably represents less than 2% of worldwide diabetes, so it's a pretty uncommon disorder. The other thing, though, that actually is more common is a number of what we call secondary causes for diabetes, or diabetes that occurs in association with other diseases or drugs. And so I'm just going to list them here. We're not going to talk about them in detail, but you should be aware that, that diabetes certainly can be influenced by other diseases. There's a condition called tropical or malnutrition diabetes. It's really not very well understood. We don't really see it much in developed countries, but has been described in situations of chronic and severe malnutrition. Gestational diabetes we see a lot of, and this is diabetes that occurs only during pregnancy and resolves following delivery. It's very closely associated with typical type 2 diabetes. Certainly disorders of the pancreas, if there's a severe pancreatitis, chronic pancreatitis, destruction of the pancreas, that can lead to diabetes. There are many drugs, we'll talk about a few of them, that can predispose to diabetes. There's more diabetes in some certain endocrine disorders, in the presence of HIV infection, diseases such as hemochromatosis, which can cause destruction of beta cells, all are associated with diabetes, and also some other syndromes like Turner syndrome, Klinefelter syndrome, some genetic disorders have higher rates of diabetes. And finally, I put down here type 1.5. This is sort of I want to say a garbage term, but it's a non-specific term for diabetes that doesn't seem to classically fit our definition of type 1 or type 2. Okay. Now, we're going to switch a little bit and talk about the epidemiology of diabetes. So how common is it? Where does it occur? What are the risk factors for it? And I think you may have seen a slide like this before, perhaps from Dr. Epstein, in the context of obesity. And this shows you the prevalence of diabetes now. Again, remembering that 95% of diabetes in the US is type 2, so this predominantly reflects type 2 diabetes. This is back in 1994. You can see that there was, on average, less than 6% of the population with diabetes, in many places less than 5%. And as time progresses, you can see that the map has changed. And so this is the most current year available in this type of analysis. But you can see there are many areas of the country now that have more than 9 or 10% of their population having diabetes. And you can see here in New York, we're in the orange category of like between 7.5% and 9%, with certain pockets within New York have much higher rates, and one of those pockets is the Bronx, right, where we have about 11% prevalence of diabetes, probably related to the very high rates of obesity and certain ethnic groups that are represented in our population. And it's not just in the United States where we have sort of an epidemic of type 2 diabetes, but this is really a worldwide phenomena. And certainly areas of the world like China, India, other countries where nutrition has changed a lot in the last 20 or 30 years are starting to see rates of diabetes that are as high as ours in the United States. So who is at risk for type 2 diabetes? Who is likely to get it? There's three main risk factors that I want you to really keep in mind. The first one is age. Right? Now, you may have heard things in the news over maybe the last 10 years or so, how we're seeing more and more type 2 diabetes, which is typically a disease of middle age and older people. We're seeing more and more of it in children or teenagers who are very obese, and that's true. But still, overwhelmingly, type 2 diabetes is the disease of middle age and older adults. And you can see here, looking at this is prevalence of diagnosed or undiagnosed diabetes by age category. And people age 60 and older, about 25% of them have diabetes. It's a phenomenally large number, so very clearly a disease of aging. The next thing that's the risk factor for diabetes, obesity. Okay, very strong risk factor, and we'll talk a little bit about why that is and how obesity sets the stage for type 2 diabetes. And the final risk factor that's really important to remember is race and ethnicity. And this is probably what's behind the genetic tendency towards diabetes, the fact that it's very familial in nature. Is the fact that different ethnic groups, different ethnic and racial groups have different genes that may predispose them to diabetes. And we'll talk a little more about that too. I'll just highlight that in the US population, that African Americans and Hispanics have more type 2 diabetes than Caucasians do. and that there are some populations around the world, including Asian and Pacific Islanders, who have very high rates of diabetes, and the highest rates of diabetes probably in the world have actually been described in the United States, in the Southwest, in the Pima Indians, where about 50% of the adults in that population have type 2 diabetes. We'll get back to that as an interesting example of environment and gene interactions a little bit later. So let's switch now and talk a little bit about what are the metabolic defects in type 2 diabetes, or in diabetes in general. And I guess here I'm going to refer again to sort of contrast type 1 and type 2 diabetes just one more time. So in type 1 diabetes, as you heard about, the metabolic defect is pretty easy to understand. There's a complete deficiency of insulin production. There is no endogenous insulin production in people with type 1 diabetes. So I kind of put it this way, that type 1 diabetes is easy to understand, no insulin, and so all the consequences of the lack of insulin you can kind of predict if you understand what the hormone insulin does. You can predict what will happen. On the other hand, it's really hard to treat because replacing insulin in a physiologic manner is very, very challenging. On the other hand, type 2 diabetes is a more complex metabolic disorder. It's associated with not only deficiency of insulin, but also an impairment of insulin action. So there's resistance to the action of insulin, and there's also inadequate insulin production. Generally, it's a relative deficiency of insulin, not absolute. So most people with type 2 diabetes do continue to make insulin, but they don't make adequate amounts. And so I tend to categorize it as it's a little hard to understand, but maybe it's easier to treat. And I think that understanding the kind of complex interplay between impaired insulin action and impaired insulin secretion and why they go together and how they both contribute to hyperglycemia, I think that's a challenge. There's a challenge for us who are in the field, and we deal with it all the time. But I do want to kind of make the point that, that this sort of complexity of, whoops, still trying to deal with this pointer. This complexity of metabolism is really characteristic of type 2 diabetes. All right. So since insulin is really at the center of diabetes, the lack of insulin or the lack of insulin action is really at the center of what goes wrong in diabetes, let's just take a minute and review what the metabolic effects of insulin are, right? Remembering that insulin is an anabolic hormone. And we're going to focus here on three of the main target tissues for insulin action, not the only ones by any means, but the three of the really important target tissues being the liver, skeletal muscle, and adipose tissue. So in the liver, insulin stimulates glycogen synthesis and the synthesis of triglycerides. So it's an anabolic stimulatory hormone, right? It also inhibits certain activities in the liver. Very importantly, it inhibits glucose production. So it inhibits glycogenolysis and gluconeogenesis, and also the formation of keto acids. In skeletal muscle, insulin stimulates protein synthesis and amino acid transport, and very sort of key to how we often think about insulin action, it stimulates glucose transport into the skeletal muscle and ends up stimulating glycogen synthesis through its activity both on glucose transporters and also on the glycogen synthase enzyme. And finally, adipose tissue, insulin stimulates triglyceride storage, in part by, again, stimulating glucose transport through the glucose transporter 4. It stimulates lipoprotein lipase and inhibits hormone-sensitive lipase. And ultimately, insulin inhibits lipolysis or breakdown of adipose tissue. And so I think it's important to kind of keep in mind what these different actions of insulin are as we talk about the defects that occur in diabetes. So, very important or central to the understanding of type 2 diabetes is this concept of insulin resistance. I think I referred to it before, where it's defined as a state in which a normal amount of insulin produces a subnormal biological response, right? And this is a very characteristic feature of type 2 diabetes. Insulin that's present does not work the way it should. And so if we think about it in terms of the different target tissues that we just named, we can say that in insulin resistance, that insulin is unable to suppress hepatic glucose production normally. In peripheral tissues, insulin doesn't stimulate glucose uptake normally. And in adipose tissue, insulin doesn't suppress lipolysis normally. So we have increased hepatic glucose production, impaired skeletal muscle glucose uptake, and increased lipolysis. And I think those are really key features of the metabolic dysregulation in type 2 diabetes, so you need to keep those in mind. Now here's just an example of impaired skeletal muscle glucose uptake from a pretty old classic experiment. But this is a study using tracer methods and clamp techniques, so very careful physiologic studies. And they compared a group of normal controls with patients with type 2 diabetes and looked at glucose uptake. So where does glucose go in the body? And they showed that glucose uptake in the splanchnic bed, in this case in adipose tissue and also in the brain, was the same essentially in the patients with type 2 diabetes compared to controls, but that the big defect was a dramatic decrease in skeletal muscle glucose uptake. And so that's a characteristic feature of type 2 diabetes. Switching again to the liver, right, looking at hepatic insulin resistance. So I guess I'll just go back and say this impairment of skeletal muscle glucose uptake is what we call peripheral or skeletal muscle insulin resistance, right? Insulin does not move glucose into the muscle cells the way it should. If we turn our attention to the liver, we can see that insulin fails to suppress glycogenolysis and gluconeogenesis, so you have increased or unrestrained hepatic glucose production. Insulin fails to decrease lipolysis and therefore fails to suppress the delivery of free fatty acids to the liver. So increased amounts of circulating fatty acids are delivered to the liver in type 2 diabetes. And insulin also fails to suppress glucagon secretion by the alpha cells in the pancreas. And glucagon is an important regulator of hepatic glucose production. And this is here to kind of highlight the fact that it's hepatic insulin resistance, the failure of insulin to suppress hepatic glucose production, that's mostly responsible for fasting hyperglycemia in type 2 diabetes. You may notice this when you start taking care of patients with diabetes or you're seeing them in the hospital. And I have patients of my own who ask me about this all the time. Many patients with diabetes will be monitoring their blood glucose by finger stick glucose several times during the day. And it's just characteristic of patients will come in and they'll show me their records. They'll bring in their meter and they say, look, I went to bed, my blood sugar was okay, it was like 130. And I didn't eat anything, I went to sleep, I woke up this morning and it was 165. Why is that? I didn't eat anything, I didn't do anything wrong. And the fact is that their fasting hyperglycemia is not really, in many cases, dependent on what they ate the day before, but it's dependent on hepatic glucose production and the fact that the insulin that they were making was not adequate to shut off glucose production by the liver. And so there's a very close association between fasting glucose levels and the amount of hepatic glucose production. Okay. So we're going to just go in a little deeper to insulin resistance. So how does insulin resistance occur? We know the metabolic consequence. We just reviewed the metabolic consequences of failure of insulin to act. But how do we get insulin resistance? And it's, again, like type 2 diabetes itself, it's a little bit of a heterogeneous picture. There are some inherited syndromes of insulin resistance. They're due to very rare mutations, either in the insulin receptor or in the insulin molecule itself. But the common forms of insulin resistance, although they may have some genetic component, they may have a pretty strong genetic component, we don't really know what specific genes are involved. There are acquired causes of insulin resistance, and I think these are the ones that tend to get most of our attention. The number one cause for insulin resistance that we are aware of is being obesity itself. So obesity, the larger someone is, the more fat mass someone has, the more likely they are to be insulin resistant. And this, at least in part, is due to the secretion of various adipokines by adipose tissue, right? That adipose tissue is a very active endocrine organ. And some of the adipokines that are secreted by adipose tissue clearly promote insulin resistance in a number of ways. Actually, adiponectin, which is a very important adipose tissue hormone, has the opposite effect. It's actually an insulin sensitizer, although levels of adiponectin are lower in states of obesity. But TNF-alpha, and actually resistin, very nicely named resistin because we know it's associated with insulin resistance, and this inflammatory molecule IL-6 have all been implicated as important mechanisms for the development of insulin resistance in the setting of obesity. Aging itself, remember I said older age is an important risk factor for diabetes. Well, one of the reasons is because there tends to be increased amounts of insulin resistance or declining insulin sensitivity with age. The reason for this is not completely clear. It may be just due to the fact that older people tend to be more obese, right? But it has been described. There are medicines that can cause insulin resistance. The most classic one are glucocorticoids, like prednisone or dexamethasone. Hyperglycemia itself may stimulate insulin resistance, and the elevated free fatty acids that are common in type 2 diabetes may also play a role. So what are the molecular defects? So let's get down a little more granular, as they say, and what exactly is going on. And I think that this is a very active area of research. A lot has been learned about it, but still there's more to know. But I think very, very simply, sort of schematically, we can think about insulin, about the molecular defects in this way. So you can define pre-receptor defects, right? So remember, insulin is a hormone. It acts by interacting with a specific receptor, like all hormones do. And so defects in the insulin molecule itself can cause insulin resistance if the molecule can't bind to the receptor appropriately, or in rare cases we have antibodies against the insulin molecule that secondarily impair the ability of insulin to bind appropriately to its receptor, and therefore there's reduced insulin action. These are relatively rare occurrences. You can have defects in the receptor itself, so a decreased number of receptors, decreased affinity of the insulin receptor, or again, you can have antibodies that are directed against the receptor, tie up the areas where the insulin would normally bind, and therefore impair the ability of insulin to bind and mediate its effects. But it turns out that the most common molecular defect that leads to insulin resistance are things that happen in the intracellular signaling part of the process. And that's responsible for the most common causes of insulin resistance. So let's look a little more closely at the intracellular signaling part. So the signaling that happens when insulin binds to its receptor is, as I said, a very complex pathway. There's multiple pathways that have been described and that may mediate the different actions or different activities of insulin. It's a hormone, actually. We often tend to think about it very simplistically in terms of its role in glucose uptake, but it actually has many other actions that are important, and we're just going to touch on them very briefly here. But we can kind of divide insulin activity within the cell into two major pathways. The first one is mediated through this kinase called PI3 kinase. And this is the classic pathway that leads to translocation of glucose transporter and leads to skeletal muscle glucose uptake. So this is the classic pathway where insulin stimulates glucose uptake. It turns out that this pathway also is responsible for increased expression of endothelial nitric oxide synthase and so increased availability of nitric oxide and vasodilation. And this is a phenomena that's observed in vascular endothelium. And that's another very important action of insulin that may not get as much attention as it should, but insulin is a vasodilator. And so you can actually see this clinically sometimes. It's a characteristic thing where you have a patient with very poorly controlled diabetes, you start them on insulin therapy, and they come back to you a week later and they've gained 5 pounds. Well, that may be partly because they were maybe a little dehydrated previously, and maybe they're a little less catabolic than they were. But one of the other factors is that the insulin that you've now provided to them acts as a vasodilator, and so they've tended to retain more fluid. So the usual response of the body in the setting of impairment somewhere in this signaling process, there's not enough glucose transport taking place, and so plasma glucose levels start to rise. The response of the normal healthy beta cells is to produce more insulin, and so there's what's considered to be compensatory hyperinsulinemia in the setting of impairment in this part of the insulin signaling pathway. But what's turning out to be very interesting is that this other pathway for insulin action that's mediated through a different kinase enzyme, MAP kinase, is actually responsible for other effects of insulin. So these are effects on growth and mitogenesis. Insulin is an important growth factor, and also can lead to vasoconstriction through actions on endothelin 1. So when you have defects here in this pathway, compensatory hyperinsulinemia, it turns out that this pathway is generally intact. There isn't resistance here, and you get a big increase in signaling in this pathway because of the increased levels of insulin. And it sort of explains to some extent some of the vascular pathology that we see in the setting of insulin resistance and hyperinsulinemia, namely that the vasoconstriction and growth-promoting effects that insulin can mediate are unrestrained, where this part of the pathway is impaired. And so that's kind of a little bit of a background for what's been described as the insulin resistance syndrome, so that insulin resistance doesn't occur usually in isolation, but often occurs as part of a constellation of findings, one of which is hypertension, which may have some relationship to the vasoconstrictor effects of insulin, and dyslipidemia, which is very common in the insulin resistance syndrome, characteristic low HDL cholesterol and elevated triglycerides. But these other factors are also part of the syndrome: impaired fibrinolytic activity, so a tendency towards prothrombosis, hyperuricemia, atherosclerosis, obesity, and type 2 diabetes are all considered to be components of the insulin resistance syndrome, which is actually the same thing as the metabolic syndrome. The older literature tends to call it insulin resistance, and currently it's more often referred to as the metabolic syndrome. But I guess the point here is that insulin resistance isn't just something that is associated with diabetes. Insulin resistance can occur independently of diabetes, but is often associated with these multiple defects. Okay. So we're going to switch from insulin resistance and to talk next about insulin availability or insulin secretion. Does anybody have any question about insulin resistance, about anything I've said so far? Yes?
The molecular defects you mentioned in those aren't just genetic defects, those are defects that are observed in somebody with normal lifestyle.
Well, so the molecular defects that are characteristic of insulin resistance, is that what you're talking about? Or right? So we're talking about the pathway, the insulin signaling pathway. So those can occur both as inherited defects, and it can occur as acquired defects. So some of the many of the genes responsible, the genetic defects or polymorphisms that are behind defects in insulin signaling, we have no idea what they are. They're not things that have been well worked out or described. Some of the acquired features that impair insulin signaling actually are related to some of the adipokines and some of the other hormones that are secreted, say, for example, by adipose tissue that actually can interfere with aspects of the signaling pathway. Anybody else? No? Okay, so we'll move on to the islet cell. All right? And I think this is really, to my mind, one of the places where type 2 diabetes gets really interesting. And so we have here a sort of a cartoon of a typical islet in someone who has normal glucose tolerance. And you can see the beta cells in pink here that are responsible for insulin production, and scattered around are the alpha cells that produce glucagon, both very important metabolic hormones. And you have over here a diagram of someone with type 2 of an islet in someone with type 2 diabetes. And you can see first these blue blobs here, and that's supposed to represent amyloid. So there's deposition of amyloid in within the islets in people with type 2 diabetes. And you can also see that there are fewer islet cells than there are over here in someone with a normal, healthy islet. But you can see, too, that the glucagon-producing cells are basically intact. So there's a reduction in beta cell mass within the islets. But there's also, we'll show you in a minute, it's not just that there's a reduced mass of beta cells, but the beta cells that are there don't work normally. So there's a disordered insulin secretory pattern. So I think this is sort of representative of the reduction in beta cell mass in type 2 diabetes. But before I go into it, I'll just say that part of the reason for confusion and controversy even in the field of the pathogenesis of type 2 diabetes is the fact that it's very difficult to measure islet cell mass in someone, in a living human with or without diabetes. We can't do biopsies of the pancreas that we might do from some other tissues. The pancreas is predominantly an exocrine organ, right, with the islets scattered throughout. Any attempt to remove tissue from the pancreas leads to release of digestive enzymes and massive inflammation, and the pancreas is just a very tricky organ to try to manipulate. Okay. Okay. So we don't have very good ways to actually examine take the pancreas out and examine it. But there have been some imaging techniques that have been developed using PET scanning and other techniques that have been able to more recently estimate the beta cell mass in a living human with type 2 diabetes. And you can see here that in this example, someone with diabetes has about a 50% reduction in beta cell mass compared to someone who has normal glucose tolerance, and actually compared to someone with a more mild hyperglycemia, either impaired fasting glucose or impaired glucose tolerance. It seems like this decline in beta cell mass may be important in terms of the progression or worsening of hyperglycemia. But I want to make the point that why is this happening? That's not the point I wanted to make. No. Could we have some technical support here? Okay. Thank you. Don't touch it. Use the mouse. Quiet, let me just hear. There's nothing on it. Okay. So use the mouse. Okay. All right. Got it. All right. So there it goes. So the point I wanted to make, not about the iPhone, is that this reduction in beta cell mass does not fully explain the defect in insulin secretion. So yes, there's a reduction in beta cell mass, but that is not the whole story. And one way that we know that this is true is that both in animal models or also in human surgery, if you take out 50 or even 75% of the pancreas, diabetes does not develop in most cases because the normal islets are able to regenerate, normal beta cells are able to increase their insulin production to compensate for even severe degrees of hyperinsulinemia or insulin resistance. So reduction in beta cell mass is not the primary cause, although it is a feature of type 2 diabetes. If we look at the defect in, so the beta cells that are there, how well do they function in type 2 diabetes? Well, we have a few insights and things that we know. One is the characteristic defect in insulin secretion in type 2 diabetes is what we call loss of the first phase of insulin secretion. So we see here the normal response to an intravenous bolus of glucose and is a brisk increase in insulin secretion, followed by a slower release over a half hour to an hour. And this brisk initial increase in insulin secretion is what's called the first phase insulin secretion. And you could see that in people with type 2 diabetes, this is completely blunted. They do respond to glucose here, but it's sluggish. It doesn't reach the peak that it should, and it doesn't even come down the way it should. It starts slowly. It goes for a longer period of time. It's dysregulated, and is one of the reasons why it's less effective. This sluggish insulin secretion in type 2 is less effective at controlling glucose levels. The other thing that's really interesting is, is the beta cells may respond to some secretagogues, but not others. So meaning some things can stimulate these beta cells and others don't. So here's sort of what I just showed you with glucose, where an intravenous injection of glucose leads to a nice insulin secretion in the normals, but blunted insulin secretion in type 2 diabetes. But if you take the same individuals over here and you give them the amino acid arginine, which also stimulates insulin secretion, it works perfectly well, right? Insulin secretion is just as good in the diabetics as the non-diabetics in this experiment. And so the point here is that there are functional defects in how insulin is secreted by the beta cells in type 2 diabetes that are responsible for the impaired insulin availability in type 2 diabetes. It's not just that there aren't as many beta cells around. And I think that's what makes it interesting, because why should this happen, right? And I think we don't really know the full story about why there's beta cell failure in type 2 diabetes. I'll share with you some of the leading theories. I think one that gets a lot of play is that the beta cells fail eventually in type 2 diabetes because of exhaustion. So in the setting of insulin resistance, the increased need for insulin production to overcome that insulin resistance, the chronic hyperinsulinemia of insulin resistance eventually just exhausts the beta cells and they fail. Glucose levels start to go up and you have diabetes. And we can't prove that this doesn't happen. It may be a component of beta cell failure in type 2 diabetes, but clearly it's not the only feature, because there are many cases, as I mentioned, where there's profound insulin resistance and the person never develops diabetes. So some people have extremely high insulin levels. They're very insulin resistant, and yet they're completely euglycemic. Another theory about why there is beta cell failure is this concept of glucose toxicity. So in this paradigm, the chronic hyperglycemia actually further impairs beta cell function. And there's definitely evidence that this is true. If you take an individual who is developing type 2 diabetes, they come in, say, to the hospital with glucose levels that are very elevated. You can measure their C-peptide, which is a measure of their own insulin production, and you can see that it's very low. And then you treat them with insulin. You bring their blood sugars down for a few days. They start to feel better. If you measure their C-peptide then, it's going to be much higher, because the hyperglycemia itself further suppressed insulin production. And when you remove the hyperglycemia, the beta cells seem to wake up a little bit and improve their function. So this happens. Another thing that tends to impair insulin secretion in type 2 diabetes is the increased circulating free fatty acid levels that are very common, right? In the setting of insulin resistance, there's increased lipolysis and higher circulating levels of free fatty acids. And there's definitely evidence that these free fatty acids may be toxic to the beta cells and impair insulin secretion. But finally, there are genetic factors, and we know a little bit, not a lot, but there's a little emerging information about what genetic factors may be responsible for sort of an inherent sensitivity of certain beta cells to this kind of metabolic stress. Now, another important thing to sort of keep in mind when you're thinking about this complex pathophysiology in type 2 diabetes where there's, in most cases, defects in insulin secretion, so there isn't quite enough insulin, but there's also defects in insulin action. It doesn't really work right. Both of those things are very important in understanding why diabetes happens. That the relationship between insulin sensitivity and insulin secretion is very important. They're very closely linked. So this is a sort of a classic a diagram that shows that as insulin, in people who are more insulin sensitive, okay, way out on this end of the curve, that the body actually needs to make less insulin, right? If insulin is working very well, less insulin needs to be secreted. And so you can see that fasting insulin as a measure of insulin secretion is low in these people who are very insulin sensitive. But as you move in this direction towards increasing insulin resistance or less insulin sensitivity, then you can see that circulating insulin levels are higher because the body is compensating for the insulin resistance. But that in general, if the individual stays on this curve, normal, healthy islets are able to maintain normal glucose levels because they can increase insulin secretion in compensation for changes in insulin sensitivity. Now, what happens in type 2 diabetes is people do what we call fall off the curve, meaning that a new relationship develops between insulin sensitivity and insulin secretion such that there is not enough insulin secretion for whatever level of insulin sensitivity that individual has, and therefore hyperglycemia ensues. One of the reasons to kind of mention this sort of complex relationship with insulin sensitivity and secretion is that sometimes we like to measure insulin levels, like I mentioned, C-peptide is a measure of endogenous insulin, and sometimes the people will look at that and say, oh, clearly this person, the C-peptide is high, and therefore they must be insulin resistant, or C-peptide is low, and therefore they must be sensitive to insulin. But you really need to look at insulin always in the context of what the plasma glucose level is at any given time. There's sort of a yin and yang relationship that you need to keep in mind. So just sort of as an overview schematic of the development of type 2 diabetes, I think a classic view is that in many cases insulin resistance may be manifest first, or you can at least measure it. And so in the setting that insulin doesn't work as well, the normal response is for compensatory hyperinsulinemia. But as long as those beta cells are able to keep up, you're going to have normal glucose tolerance. But over time, or as a result of some genetic defect, if there's impaired beta cell function, then you'll have declining insulin levels and first manifest as impaired glucose tolerance and ultimately frank type 2 diabetes. It's a little bit of a chicken and an egg question, I think, about whether the impaired beta cell function comes first or impaired insulin sensitivity comes first. But I think, and that's really unanswerable, I think, in most cases. But the point I really want you to keep in mind is that insulin resistance is a very characteristic feature of type 2 diabetes. But you have to have impaired beta cell function in order to get diabetes. It's not purely a function of insulin resistance, but there always is an impairment of insulin production as well. So we referred before to the genetic influence on type 2 diabetes, so we're just going to talk a little bit more about that for the next couple of slides. In contrast to type 1 diabetes, which has its genetic component as well, the genetic basis for type 2 diabetes is actually much stronger. And if you look at the 90% concordance among monozygotic twins, that tells you a lot, right? And that about 40% of people who have type 2 diabetes have at least one parent who has type 2 diabetes as well. In addition, first-degree relatives of people with type 2 diabetes, even when they're not diabetic themselves, can be demonstrated to have defects in glucose metabolism and ultimately are at higher risk for diabetes. So there's something going on genetically that's very potent in the risk for type 2 diabetes. We mentioned before these monogenic forms are extremely rare. The common forms of type 2 diabetes are polygenic and multifactorial. And there really is a complex interaction between genes and environment that we'll get to in a second. Yes? Right. Perfect question, right? Since people born to the same family often are raised in the same family and have the same environmental risks as well. I think the best studies to help identify this kind of thing is monozygotic twins reared apart, right, adopted. And believe it or not, there have been studies that have done that and have demonstrated that this concordance is really genetic and not environmental. But that's a very good point. Mm-hmm. Mm-hmm. Right, right. Well, I mean, I think that's part of the paradox, right? I think that the typical type 2 diabetic will have an impaired response to glucose, but not to arginine or some other secretagogues. So there's something specific about the response to glucose stimulation that is inherent in the process. In type 1 diabetes, there is destruction of the beta cells, so there is no insulin production. Right? So as I said, it's easier to understand in type 1 because it's just like you had a surgery and you removed all the beta cells. That's it. There's no insulin. It's much more of a functional defect that's actually that's in type 2, and it's not consistent for all the different secretagogues. So talking about the genetic influences, as I said, it's for garden variety, common forms of type 2 diabetes, there probably are multiple genes that are involved, and we've identified some. This is a slide that shows you just in the last, since maybe 8 or 9 years, the number of different genes that have been identified as being associated with type 2 diabetes risk. But the thing I will show you here, number one, is that the effect size for any of these genes is very small, meaning the amount of the differential risk for type 2 diabetes that's explained by any one of these genes is very small. The one with the biggest effect size is this transcription factor, TCF7L2, which has received a lot of attention. But even that is responsible for a very small proportion of the risk of type 2 diabetes. Most of the genes that have been identified so far, based on genome-wide association studies and other types of studies, have been genes that have been involved in insulin synthesis and insulin secretion or pancreatic development, and not so much on insulin sensitivity, for whatever that is worth. But clearly, this is a big area of interest, to try to define what are the genetic abnormalities specifically that are responsible. Now, we're going to talk a little bit about gene-environment interaction. I think this is a very interesting example. Remember, I mentioned earlier that the Pima Indians in the southwest United States have some of the highest rates of diabetes in the world. About 50% or more of the adults in the Pima Indians eventually develop diabetes. And so there's been a very interesting experiment of nature that there are tribes that were derived, one tribe of Pima Indians that actually split up a couple of centuries ago, with part of the tribe migrating to the U.S. and taking up residence in the Southwest, and the other part of the tribe staying in Mexico. And that's true even to this day, that there are people with the same genetic background, the same ethnic group, are living much more of a subsistence occurrence in farmers and mostly involved in farming in Mexico. And then there are the Pima Indians that live, many of them on Indian reservations in the American Southwest. So this is the best picture I could find of Pima Indians in their more indigenous habitat, although I don't think it's very recent. But these would represent to us the Pimas who stayed behind in Mexico. And the Pimas who are in the United States, so these groups are sharing their genetic background is identical. But the first thing you see about the Pimas in the United States is what? They're very obese, right? They've tended to become very overweight, which is probably itself genetically determined. But if you look at the rates of diabetes in the two populations that are genetically from the same founders, the same, very, very similar, that the rates of diabetes in the U.S. Pimas is very high, whereas the Pimas who stayed in Mexico living by subsistence farming and not developing obesity have very, very low rates of diabetes. So a classic example of gene-environment interaction. And these kinds of observations have led to this concept of the thrifty gene. Has anybody ever heard of this thrifty gene hypothesis before? So I guess it kind of gets around. But the idea is that, over millennia, centuries, many years, that intermittent starvation and, high physical activity levels really leads to genetic selection to people who have metabolic efficiency, thrifty genes, so people who are able to maintain body integrity and functioning with limited resources. So whatever these genes are, they allow the organism to survive through periods of starvation. And then there's acute modernization with rapid increased availability of calories and fat and reduction in physical activity. And these same people who were formerly at an advantage because they had the thrifty genes now are most at risk for development of obesity and type 2 diabetes in the setting of rapid and sort of universal availability of calories. And we think that some variation on this is probably responsible for what's happened to the Pima Indians, as well as other groups, other ethnic groups that have had low rates of diabetes in their native environment, and then when they come to the United States, they start developing obesity and diabetes. This has been observed in Japanese Americans, and it's been observed in Pacific Islanders, as I mentioned. So this is not an uncommon phenomena, although, as I said, we don't really have identified yet what these thrifty genes might be. But as a paradigm, I think it's an interesting one. But it highlights the fact that the key factor, the key environmental factor here is obesity. And it is definitely true that about 90% of people who have type 2 diabetes are either obese or overweight. And so it does point out that there are some people who have what classically looks like a type 2 diabetic phenotype. They make insulin, they may be insulin resistant, they're not a type 1, they're lean, and so you can have diabetes, type 2 diabetes without being obese, but the overwhelming number of people with type 2 are obese. And this just shows you the relationship between body mass index as a measure of obesity and the relative risk of diabetes. This study was done in women, but there's a similar relationship in men. And it shows you that the relative risk of diabetes for someone who has a BMI of 35 is 10 times higher than someone who has a BMI of 25, and that the risk of diabetes actually still, the relationship between body mass index and diabetes risk actually persists even into the normal range of BMI. So very strong relationship with with adipose mass and obesity. So just to kind of summarize the risk factors for type 2 diabetes, we mentioned that ethnic background, predominantly in the United States, non-Caucasian people have higher rates of higher risk of type 2 diabetes, and family history is important. So these are the genetic features. The environmental features are obesity, especially central adiposity or visceral adiposity is a very important risk factor. Physical inactivity. So these are two of the very important environmental influences on diabetes risk. There are some drugs that tend to promote diabetes, and we'll talk about it in a minute. But one thing I just want to mention in passing, also because it's really fascinating, is that it turns out that intrauterine exposure can predict later type 2 diabetes development in adulthood, specifically low birth weight. So a fetus that's developing in the setting of reduced nutrient availability because of, say, placental insufficiency or some maternal illness, they're born at low birth weight, that these children are at higher risk for type 2 diabetes later in their life, pointing out that metabolic programming may be happening in utero that changes this perhaps islet development or in some way the islet regulation that later leads to type 2 diabetes. And women who've had gestational diabetes are themselves at risk for type 2 diabetes later in life, but sort of the flip side of low birth weight babies, high birth weight babies are babies that were exposed to their mother's type 2 diabetes. So mothers who had gestational diabetes during their pregnancy, those children are also at higher risk for type 2 diabetes later in life. So I mentioned that there are some drugs that can influence diabetes, and there's a very long list, but I picked out some of the ones that I think are the most common players. By far the most common drug that's used clinically that will cause blood sugars to elevate is glucocorticoids. Not really unexpected. You even look in the name of the drug and you can expect that that's going to cause problems. And so since these drugs are used very commonly, we often see someone who's being treated with high doses of steroids for asthma or part of treatment for cancer or to treat some rheumatologic condition. Very frequently they will develop previously undetected diabetes. There are certain HIV protease inhibitors or other HIV drugs that seem to induce insulin resistance and may be associated with diabetes. Niacin, which is used as a drug for dyslipidemia in very high doses, definitely impairs glucose metabolism. And I put this in here also because it's very common. A lot of the drugs that are used for organ transplant to prevent rejection, like cyclosporin or tacrolimus, are very characteristically can increase the risk of diabetes to the extent that there's a term for it, new onset diabetes after transplant, or NODAT. And there's a very high rate of diabetes developing in people after they've received an organ transplant because of these drugs. Antipsychotic drugs, especially the atypical antipsychotics, many of them lead to really dramatic weight gain and are associated with diabetes. And then two drugs that are commonly used to treat hypertension, thiazide diuretics and beta blockers. Over the years, there's been evidence that they probably do also, at least at higher doses, increase the risk of diabetes. So what does diabetes look like? Oh, no, we're running out of time. OK, I'll try to get through quickly. Most cases of type 2 diabetes are detected incidentally or on routine screening. The symptoms of polyuria and polydipsia tend to happen only when the renal threshold for glucose is exceeded. So people who have hyperglycemia below those levels often can have no symptoms. So diabetes can be present for decades sometimes before it's recognized. Occasionally people present for the first time with established microvascular complications. And sometimes people present in very decompensated states like diabetic ketoacidosis or the sort of type 2 diabetes equivalent to the hyperosmolar state. Now, you saw a slide like this, I think, from Dr. Shamoon that described the metabolic factors that lead to diabetic ketoacidosis. But I think in the hyperglycemic hyperosmolar state, which is a severe decompensated hyperglycemia that's characteristic of type 2, where there's relative, not absolute insulin deficiency, that we do get increased gluconeogenesis, we do get decreased peripheral glucose utilization, as we talked about before, resulting in hyperglycemia. But in this case, because there still is some endogenous insulin secretion, it's not an absolute insulin deficiency, you don't get the ketosis and the acidosis that you see in diabetic ketoacidosis, but you can get profound dehydration, hyperosmolarity, and coma. And in this entity, this non-ketotic hyperosmolar coma has a very high mortality rate, especially in the elderly. So the treatment of type 2 diabetes, we're going to talk about next week a whole session on drugs, and we're going to talk about the screening, prevention, and treatment of diabetic vascular complications. So I'm just going to say the next couple of words about lifestyle, which really is the essence of type 2 diabetes treatment, although we have to admit it's a little frustrating. So what are we going to say about nutrition, right? Really important. We're talking about carbohydrate metabolism, right? So obviously nutrition is really important. So what is the focus for nutrition in type 2 diabetes? The focus is weight loss, right? That is probably the most important factor for regulating blood sugar in people with type 2 diabetes. And we do this primarily through calorie restriction, smaller portion sizes, moderate carbohydrate intake, because carbohydrates are the food that are the nutrient that's most responsible for raising glucose levels. Proteins and fats don't do it very much, so moderate amount of carbohydrates. We usually recommend they avoid concentrated sweets, and we also avoid saturated fats because of the very high cardiovascular risk that's associated with type 2 diabetes. So weight loss is the focus. Type 1 diabetes is very different. Most people with type 1 are not obese, and the focus there is not to restrict their diet, but for them to learn how to match the carbohydrate that they're eating with the insulin that they're taking at any mealtime. And they could do this by learning to adjust their insulin based on their carbohydrate intake, or by developing an eating style that has a very consistent amount of carbs at every meal so that their insulin dose will be able to accommodate it. And that in general, they should have a healthy, balanced diet, but we don't have any specific prescription about macronutrient distribution for most people with type 1 diabetes. Okay, sugar. There's a lot of myths about sugar. Most people say that they think that eating too much sugar causes diabetes, and I would say that there's very little evidence for this. It's also not true that people with diabetes have to avoid sugar altogether. No, that's not really true. Carbohydrates are important, but sugar is just one of several carbohydrates. And so I guess the facts are here, that obesity is the major risk factor for type 2 diabetes, and whether you achieve your obesity through eating sugar or fat or protein is probably much less important. So it's the total caloric balance that's more important, I think, than whether it's sugar or not. And that any form of carbohydrate will raise blood glucose, so singling out table sugar and not looking at complex carbohydrates like rice or pasta or bread, you're going to miss the mark. Any carbohydrate will raise blood glucose levels in someone who has diabetes, so moderate, consistent carbohydrate intake is appropriate. No single nutrient is really the devil or forbidden for people with diabetes. And I mention this in part because I think if you talk to people who have diabetes, they get a little irritated when they're having lunch with their friends, or they're eating in a restaurant and someone says, oh, you have diabetes, you shouldn't have that piece of cake. I think that balanced diet with moderate amount of carbohydrates is really the key. Another thing that we don't talk about as much as we should is exercise. And exercise can have a very potent influence on glucose regulation in people with diabetes. This is just one of several experiments that showed that a combination here of resistance and aerobic training was more effective than either one by itself. But all of these forms of exercise were better than control in terms of reducing hemoglobin A1C in people with diabetes. So insulin sensitivity will improve with exercise, even if there isn't any weight loss. There's improved oxidation of fat, and overall glycemic control can improve. So that is a very important thing. So I just have like 5 more minutes. Do you want to go through this, or you want to skip it? You can wait? 5 minutes? Okay. So I want to talk to you a little bit about the prevention of type 2 diabetes. And I partly put this up because it's a very important issue, but also because we were one of many sites here for something called the Diabetes Prevention Program that really led to some very important observations about the preventability of type 2 diabetes. I think the notion here is that most people who end up with type 2 pass through sort of an intermediate state of pre-diabetes or impaired glucose tolerance before they get diabetes. And the idea is, what if we can prevent this from going to this, and then we can prevent the complications and the ultimate disability. So this study was designed to test whether an intensive lifestyle intervention that was designed to achieve weight loss, plus increase in physical activity. This program compared to a diabetes drug, metformin, which we'll hear more about next week, or a placebo, if either of these interventions would reduce the development of diabetes in this group of people who were at very high risk. And just to cut to the chase, yes, both of them work. The diabetes, the cumulative incidence here of diabetes over about 4 years was reduced by 58% in people in the lifestyle group, and by about 30% in the people in the metformin group. So highly effective in preventing diabetes. And it turns out that analysis from this same study showed it's, at least in terms of the lifestyle intervention, it was the reduction in weight that was responsible for the prevention of diabetes. It shows you that people who lost weight had a lower rate of diabetes, and people who gained weight had higher rates of diabetes. A very clear relationship between weight loss achieved and the reduction in diabetes risk. So to summarize then, for type 2 diabetes, it's a complex and heterogeneous disorder, very common, affecting more than 8% of the US population and much higher in certain subgroups, as we discussed. Substantial morbidity and mortality, enormous social and financial costs can be prevented. And I think the final bullet here is something that we don't have time to talk about, but I think that effective treatment for this sort of epidemic of diabetes really will require public health commitment in terms of changing the way kids eat in school, making exercise more feasible, kind of changing our view of what constitutes a healthy diet, and helping the population as a whole achieve and maintain normal weights. Okay, sorry I went over. I'll see you again on Monday.